Good morning everyone. Myself Dr. Priyanka Agarwal, pediatric cardiologist and cardiac electrophysiologist, appointed as an assistant professor in UNMICRC Institute of Cardiology and Research Center. So today we are taking a lecture on lead extraction. I don't know how many people of you might have heard the word lead extraction. So it is an important topic since the number of devices which are getting implanted nowadays, the cardiac devices are being in an increasing trend actually. I think in UNMICRC itself only we are implanting around 500 to 600 devices per year. So since we are implanting devices, so we might be encountering such patients in the OPD nowadays, like with a high frequency, I guess. So what do you see here? These are basically device erosions. In the first picture, we might see here that the device is superficial and the lead is basically, we can see the leads which are placed on the upper surface of the device basically. So lead and the device is coming out. The second picture also, it is implanted more lateral, so it is coming out. The third picture, there is a sinuses which is being formed, and the fourth picture, the whole device and the lead are coming out actually. So we are encountering such patients in our OPD nowadays. So we need to discuss the management of these patients also. Just implanting the device is not the only solution. We need to learn or read about the management of the adversities or the complications of the device implantations also. So most of the people do have that tendency, just implant the device and that okay, they have made a big deal. But no, we need to learn the management of these patients also. So to begin with, certain terminologies we should know. So what do you mean by a non-functional lead? A lead that is not usable due to the electrical dysfunction, like there can be a coil fracture or an insulation breach. So that is a non-functional lead. What do you mean by an abandoned lead? Abandoned lead can be functional or non-functional, that is left in place and is not connected to the device. So in this lecture we are supposed to discuss is the lead removal procedure. The lead removal procedure is any procedure involving the removal of a pacing defibrillator lead or a pacing lead using any kind of technique. It can be a lead explant procedure or a lead extraction procedure. So what is lead explantation? What is lead extraction? So lead explantation is basically a simple procedure in where all the leads are removed without using specialized tools. So removal of the lead implants like using the implant stillet only, and usually lead explantation is done like when the device is being in place for less than a year, because it is assumed that when the device has been in place for more than a year, the amount of fibrosis is so much that just putting a stillet and giving a small amount of traction will not remove the lead. So now we come to the lead extraction procedure. So like what is a lead extraction procedure? A procedure where at least one lead removal requires the assistance of specialized equipments or the lead has been in place for more than a year. So what are the indications of lead removal? So the most common indications for the lead removal is is infection, the CID infection with infective endocarditis or a pocket infection or a valvular endocarditis, or there is a persistent occult gram-positive bacteremia. The other indications can be a chronic pain, like the patient is having pain at the device implantation site, which is refractory and which is not manageable by medical or any surgical techniques. In that case, we need to remove the device since we are left with no other options. The other indications is thrombosis or venous stenosis, like a clinically significant thromboembolic events associated with thrombus on a lead or a lead fragment, bilateral subclavian vein or SVC occlusion, plant stent deployment in a vein already containing a transvenous lead, like some subclavian vein stenosis is there which is symptomatic. We are planning to do a stent implantation, but we cannot keep the leads in position and then deploy a stent. We need to take out the system, then put a stent, dilate the vein, and then again need to do the device. So in that case we need a lead extraction procedure. Other indications are like in case of functional leads, It can be a life-threatening arrhythmia secondary to retained leads with design failure that may pose an immediate threat to the patient if left in place, leads that interfere with the operation of an implanted CID, or if a patient needs to go a malignancy therapy, like a radiotherapy for some malignancy, like if patient is having a left-sided breast carcinoma and the device is on the left side, the patient needs to go a radiotherapy for the same, then we need to remove the device and implant it on the other side. Or the other indications are like MRI, like if there is no other alternative to MRI, the patient needs to go an MRI, then in that case, if the device is MRI non-compatible, we need to remove the device and then we have to take the patient for the MRI. If the non-functioning leads is causing any life-threatening arrhythmias or with design failure that may pose an immediate threat to the patient if left in place, leads that interfere with the operation of an implanted CID, or if there are more than 4 leads on one side or more than 5 leads through the SVC, which is basically like causing stenosis or edema, facial edema or something symptomatic, then we need to remove those leads also basically. Other than the indications, what can be the contraindications? So it is being said that the infection has not, the patient has come with some infection over the implantation site and the infection has not reached the device, or it is very superficial, then we can give a trial of antibiotics and for 1 week, 10 days, and then we can call the patients. Or there is any bacteriemia due to some other cause, not because of the device, and we have found out the cause, whether there is a UTI or something, then there is no need to remove the device. Or if the patient's life expectancy is less than 1 year, then we can still wait. Or if we know that the lead which has been placed, it has taken another route, like other than the normal venous or a cardiac structure route, like it has gone through an subclavian artery, aorta, pleura or mediastinum, then we should not plan for a lead extraction, or we can plan for like transvenous lead extraction we should not plan, or we can plan a surgical lead extraction in that case. So before we plan a transvenous lead extraction, we do a CT actually to look for the course of the leads, like whether it has not taken any abnormal route like through the mediastinum or anything. In that we get to know okay. So moving ahead, we'll see like what are the types of lead removal procedures. So the lead removal procedure can be done in a cath lab, the transvenous lead extraction, or it can be an open surgical procedure which can be done in the OT, or it can be a hybrid procedure, like both included actually. So here we will be majorly discussing the transvenous lead extraction procedure. So transvenous lead extraction procedure, it has basically a superior approach like the IJV approach from where the device has been implanted, or the second is the femoral approach. So we'll again the most common approach which we use is a superior approach only. If the superior approach we feel that it is not possible or the lead has cut or something, then we go to the other approach, the femoral approach. We'll discuss this approach later in detail. So moving ahead, so I was discussing about the special equipments used in transvenous lead extraction. So first is a lead locking stillets. So what is the difference between the implantation stillet and the lead locking stillet? The implantation stillet just fixes at the tip, at the lead tip. The lead locking devices are more like they fixes the lead throughout the length, not just at the tip. So it helps in preventing the integrity of the lead basically. So there are various companies which are providing with the lead locking devices. So first is, which we use in our setup, is Philips Spectranetics LLD devices. The other is the Liberator, which just locks the lead at the tip. The other is Bulldog. So so here in the first picture you might be seeing it. When the lead is undeployed, like the LLD is undeployed, it is thin. The moment it is deployed, it becomes fat. Okay, so that is the thing, that once the lead, the LLD has been deployed, then it cannot be reused or it cannot be taken out. So here this is a detailed picture of the LLD, basically spectranetics LLD. Here we can see the radiopaque marker at the tip. There is a proximal connector and the mandrel and the loop, basically distal loop. The moment we push the proximal connector, the mesh is being deployed and the LLD becomes fat, and so then it is basically, it can be used in a lumen, in the leads with a lumen only, not in the leads without a lumen. Like the lead which is like which we use for conduction system pacing, that doesn't have a central lumen, so we cannot use this LLD in this lead extraction procedure for any conduction system pacing. In that case, we need to use this bulldog or some other stillet. So yeah, this LLD can be used only in the leads which have a central lumen, either a pacing lead or a defibrillator lead. So moving ahead, we now have dilator sheaths, which can be a mechanical dilator sheaths or a telescoping sheaths. Mechanical dilator sheaths can again be of are composed of different materials, like it can be a stainless steel, Teflon one, or the polypropylene one. And the mechanical dilator sheaths basically are advanced along the lead to disrupt and dilate the encapsulating fibrotic attachments, to free the lead from the encapsulating fibrotic attachments. And we use the mechanical this force over it. There are no powered, this is not powered actually. The other powered sheaths are also there. So other is the mechanical rotation cutting sheath. The first one is Phillips tight rail sheath, and the second one is the Cook sheath. What we use in our setup is the Phillips tight rail sheaths. So here we can see here in the diagram that at the tip there is some cutting blades are there at the sheath, and there is one trigger. It's like a gun sheath basically. The moment we press the trigger, the cutting blades at the tip of the sheath will rotate and it will cut basically the fibrotic tissues or the encapsulating capsule which is around the lead, and it will try to free off the lead from the surrounding tissues. So next is like how is the traction counter traction mechanism works basically. Like why is the lead locking stillet, why do we use both the lead locking stillet and the dilator sheaths in combination? So basically the logic is that if we just apply the traction force using a lead locking stillet, then what will happen? The myocardial will invaginate and there is a higher chance that myocardial avulsion will occur. So we need to stabilize the myocardial wall, and then we need to put a traction along the stillet. So for applying a counter traction force, there is a sheath basically. So that will stabilize the myocardial wall, and then we can apply a traction on the lead locking stillet. No, it is not like that if we use the sheath there is no chance. Still there can be a chance for myocardial perforation and all the moment the lead gets taken out from the myocardium wall. So again the third kind of sheaths are laser sheaths. We are not using in our setup. I don't know in India where these laser sheaths are being used, but yes, they are the upcoming actually sheaths. They basically use laser energy. The laser energy is used in pulses. The tip of the sheath delivers a ring of laser light in pulses to deliver to a tissue depth of 100 micromillimeters, so that only the tissue immediately in contact with the sheath tip dissolves, and the fibrotic tissue encapsulating the lead body is removed in a controlled manner, and occluded vasculature can be recanalized basically. So here we can see the laser extraction sheath. There is a console and there is a xenon chloride is the what we used in the basically a cold laser actually, which we use in laser extraction. The other technique is a femoral extraction technique, which we were discussing previously actually. So the femoral approach is not on a priority approach, it's a second approach, and it is helpful when access or extraction via the implanting vein is impossible, or when the leads are fractured or cut. Needle size snare is the most frequently used tool for the lead extraction via the transfemoral approach. Usually the use of femoral snare is the last step in the transvenous lead extraction. So these are the snares which are being used in for transfemoral lead extraction. So here we will discuss in brief about the lead removal procedure, the technique, the imaging techniques and everything. So like how do you prepare a patient for a transvenous lead extraction? So we need to do what we do in our routine setup is history, physical examination, optimize hemodynamics, anticoagulation, and detailed CID evaluation, interrogation. Pre-procedural imaging is very important actually. So X-ray should be done, transthoracic echo should be done, CT should be done, fluoroscopy should be done, patient should be taken in the lab, and detailed fluoroscopy should be done in AP view and the lateral view, so that we can see that how many leads are there, what kind of leads are there, like whether it's a screw leads or the tine leads, and venography should be done. And by doing all these imaging techniques, we can define the extraction approach and procedure goals. Informed consent of the patient should be taken. The metabolic CBC coagulation profile should be done. Large group bore venous cannula in central vein should be put. Blood group cross matching, at least keep 4 PRBC ready. DFib patch should be attached. Device programming should be done in a VO mode. Turn off the DFib therapies, and art line should be taken, continuous SpO2 monitoring, TPI should be implanted, and TE. In our center we don't put a TE, but in some centers people do put a TE to so that we can have a continuous monitoring for that, like whether during the lead extraction any pericardial tamponade or something like it is there or not. And there is some bridging balloon is there, so we do put in from the femoral approach. So in case of emergency SVC tear, we can just put a bridging balloon high up in the SVC, and we can just inflate the balloon, and it just gives patient time to shift to the OT or something, to the OT for emergency this. So lead explantation protocol, just to have a brief: open the pocket, blunt dissection to bring out the pulse generator, carefully dissect the leads and detach it from the PG. Remove the sutures and dissect the leads free. Insert the stillet till the tip of the lead, and unscrew. Leads free and leads free at the venous entry side. Manual traction, and that's it. And the lead will just come out, and it's okay. If it lead explantation is not successful, if we are not able to just take out the lead by just putting a simple stillet, then we need to go to the lead extraction protocol. That is basically we put an LLD through the central lumen, and if the lead is still not and we just apply a slight bit of traction, if it is not still extractable, then we need to put sheets, which can be mechanical dilator sheets, or it can be tight rail sheets, or a laser sheath. We apply a counter traction, counter traction, and just try to pull the lead. If the lead gets cut or something like that, or if it is cut or damaged or something like that, then we need to use the snaring to remove the fragments from the IJV or the femoral approach. So what can be the complications of this transvenous lead extraction procedure? Yeah, one more thing. One is the other thing is that whenever we try to attempt a transvenous lead extraction procedure, there should be always an OT standby. The surgeon should always be informed, because if any complications occur, then we need to take the patient in OT, and for emergency and high risk consent from the patient should be taken. So yeah, moving ahead, just discussing briefly the complications of transvenous lead extraction. So the major complications, yes, on-table death can occur, cardiac avulsion or tear requiring thoracotomy, pericardiocentesis, chest tube or surgical repair, vascular avulsion or tear, pulmonary embolism requiring surgical interventions, respiratory arrest, stroke, pacing system related infection of a previously non-infected site. The other complications can be pericardial effusion not requiring pericardiocentesis or surgical interventions, hemothorax, hematoma at the surgical site requiring reoperation for drainage, arm swelling or thrombosis of implant veins resulting in medical interventions, vascular repair near the implant site or venous entry site, hemodynamically significant air embolism, migrated lead fragments without sequelae, blood transfusion related to transfusion loss during surgery, pneumothorax, or pulmonary embolism, not requiring surgery. So here we'll discuss a case actually. We recently, like 1 month back, we had this case. So he was a 56-year-old male. He went dual chamber pacemaker for CHB in 2011. Then we did an PGR in September 2023. Then later on after PGR, like after 1 month, he came on a follow up with this. We looked at the device site and this was the site actually. So pus was coming out and all. It was all red and all. So we planned a lead extraction procedure for the same patient. So I tried to download the videos basically, but the videos I was not able to upload. So I'll just show you the pictures actually. So this is the initial fluoroscopy which we did, dual chamber pacemaker. We did put a TPI in place. So here we can see that the atrial lead came out with just a simple traction, not requiring any mechanical dilator sheets or anything. Then like for the RV lead, we used this mechanical dilator sheets and all, and we tried to dissect it from the vein wall, but while dissecting, the lead got cut actually. So then we tried to extract this lead from the transfemoral approach. We snared it using an EP catheter and the snaring catheter, and we were able to remove this one. So yeah, the patient the procedure took around 2 hours, and the patient was shifted to the post-cath, and like 1 week, 10 days later, we implanted the device from the other side. So yeah, other than like transvenous lead extraction, we need to know about the surgical lead extraction also. Like what are the indications for the surgical open lead extraction? So if we are not able to extract the device via transvenous approach, or there are large lead masses like more than 2.5 centimeters, it can be vegetations or thrombus, which can embolize during transvenous lead extraction, then we send the patient directly for surgical lead extraction only. Or if the patient has other reasons for cardiac surgery, then the surgeons can do simultaneously the cardiac surgery along with this lead extraction. Okay, thank you.